So I think really importantly, first of all, we should introduce ourselves properly, and I'd love you to start. You're far more interesting than me.
Not at all, not at all. Thank you very much, Roz. So I'm Dr. Raj Sharma. I'm the Clinical Lead Executive for Urgent and Emergency Care for BCWB-CCG, which is the Black Country and West Birmingham Clinical Commissioning Group. I'm also the Strategic Executive for Clinical Partnerships there as well. And that's what I do. I'm a GP by background. I'm also, my background is clinical radiology. My view is that we should be collaborating in a far more strategic way in order to help our patients get the care that they need in the community.
That's really, I mean, you do all sorts of things, and you're sort of working locally, nationally, primary care, secondary care, and all sorts of other things as well, I think. So I'm the managing director of an organisation or a team called Thrive by Design, and we're really interested in tackling health inequalities and using digital to tackle health inequalities. And we're also interested and passionate about making sure we don't compound pre-existing health inequalities with the digital transformation of health and care. And we've been sort of working up and down the country with all sorts of people, voluntary sector organisations, integrated care systems, NHSX as was, and so on. And we've learned all sorts of things with all sorts of people. Actually, what we did as well, we promised that we would share everything we've learned. So we've put it onto a future NHS workspace called Inclusive Digital Transformation, if anyone wants to know. And then the other thing I wanted to bring into the room today is that I live with type 1 diabetes and have done for 20 odd years. And the reason I got into digital was actually it's really helped me. It's really sort of transformed how I manage my care, how I connect with my community, how I find out about information. And it really bothers me that not everybody has access to that level of sort of connection, if you like, with the things that we need. So that's why I do what I do.
Great, and I think that's really, really important. The conversation we need to have is what is it that we can do from a digital perspective, but from a patient-centered perspective as well. Tech is great, tech is wonderful, but it's about using the right tech with the right patient at the right time and making sure we individualize what we need for that patient. Absolutely, and I think there's many wonderful, wonderful things that are going on. The pandemic has been horrendous for obvious reasons, and it's affected families, it's affected communities, and of course it's affected the NHS at large. But the silver lining of the pandemic has been the acceleration of and innovation of tech and solutions within the primary care space. Historically, tech and the adoption of technology in the NHS, especially from a primary care point of view, it's been okay, but it's never really been on steroids. And the silver lining of the pandemic is that we've had to adapt very quickly to make sure that we can reach those patients because we had to in a different way. So some of the good examples of that is that, and it might sound simple, but we weren't doing them before the pandemic, is that, for example, I can now text my patient straight away with information that's important. You've missed your appointment in respect of this. We need to keep your blood pressure in check, because of the risk of stroke, because of the risk of cardiovascular disease. We need to make sure your immunizations for your child, you've missed them, can you rebook and get those done? Can you come in and actually, can we coordinate your disability care? Because we haven't seen you for a while in the pandemic. Are you okay? Can we book an appointment for you? That kind of interaction has been great, and that wasn't happening before in this way. I think one of the other things that's innovated greatly in the primary care space is using other types of technology. So, for example, let's take the pandemic. Patients got coronavirus. They're not doing well. They want to speak to their GP. They're at the cusp of potentially going into hospital, potentially not. Virtual ward rounds in that situation have been great. So my patient calls me. They're hitting a certain amount of threshold for needing a bit more active monitoring, but not quite enough to go to hospital. So what do? We coordinate their care. We get the rapid response team equivalent for coronavirus, which we set up locally, to go in, to give them their oxygen monitoring equipment, to give them a blood pressure machine, and they have a virtual ward round. And that information, that objective data, is then put on a dashboard, and that patient's monitored 2 or 3 times a day. We weren't doing that before. What are we doing? We're improving care. We're making sure that care is appropriate. We're making sure that care is escalated appropriately, so if that patient needs to go into hospital, we can identify it in a much more meaningful way. I mean, that's essentially the intensive care model. When a patient's in intensive care, they have ready available dashboard metrics, objective metrics. We are now doing that in primary care. We are keeping the right patients at home where they want to be, and the right patients that need the intensive care treatment in hospital and everything in between. So we're really managing the resources there better. I think the other example of tech innovation that's been great is understanding that the primary care space is not just about general practice. Now, it might sound like an obvious point to Labour, but it really is not just about GPs. The primary care space is about every other type of clinician in the space. It's about your advanced nurse practitioner. It's about your community pharmacists, who, by the way, in the pandemic have been absolutely wonderful. It's about your clinical nurses who will go out and do your home visits for you. It's about the midwives. It's about the specialist care coordinators. It's about podiatrists. So it's the whole space we've got within the community of primary care and enabling that. And that's where I think the gap in the technological divide is. And if I can just give you an example of that, let's break it right down. So imagine Mrs. Jones goes to see her community pharmacist, and she's got an ailment. And by the way, a lot of pharmacists can prescribe by 2026, I believe, and if there's any pharmacists here, feel free to correct me, but they'll be coming out of their pharmacy training being prescribers. So we've got a great resource there. But pharmacists can prescribe. Mrs. Jones needs a particular medication that's prescription only, so it can't be bought over the counter. Pharmacist wants to be able to help this particular individual, but they haven't got access to the record. And if they do have access to the record, it's only the summary care record. So they're already at a disadvantage. They don't know the context of the patient. They don't know the other medical conditions. And they don't know what drugs are going to interact with what they want to prescribe. Would you, as a pharmacist in that situation, be willing to prescribe a medication? Maybe you would, maybe you wouldn't. But you're doing it in an area of increased risk, potentially. And also, if they go ahead and prescribe something, which they may be very competent to do, and many, many pharmacists are, there's no way of them informing me, as a GP, that they've done that. There's no way of the next medical professional, clinician in the community or the hospital space knowing that that was the plan at that time and who was it that did that. There's no link up there. So it's all very well having the digital divide and trying to, potentially, hypothetically, let's give everybody an iPhone or an Android phone and there you go. But it's actually more nuanced than that, because if we don't sort out the digital inequalities at system level, where these things talk to each other, nothing else really will work properly. So that's where the divide is, and that's what we need to do.
Yeah, I want to talk about the other side of the digital divide as well, and sort of really the unintended consequences of this rapid digital transformation of health and care, which I think is really important, and I'm glad that we're doing it, I should say. But actually there's sort of 10 million people who aren't easily able to access digital in lots of different ways. And those people are more likely to be older, living with disabilities, living in poverty and so on. And that group of people, or those groups of people, are more likely to need health and care services. So
Absolutely.
there's a big flaw in the plan if we're not addressing digital inequalities. And I think sometimes we revert to, we'll just give people a device or build digital skills. And it isn't that simple. So we've done all sorts of research across the country, looking at lit reviews and surveys and interviews and all the rest of it. And the sort of things that we've kind of categorised stuff into three areas. You could do this in lots of different ways, but we've chosen to look at things like life context. Yeah. There's a whole set of factors that get in the way because of the stuff that's happening to us in our lives. So it might be that people are living very precarious lives, that they don't have a private space at home. There's there's barriers around physical and mental health conditions. And all sorts of other stuff, housing, employment, and so on. And then there's another set of factors which I think are quite well known around digital skills, confidence, and capability. And what I think is there's a root issue here as well around poverty of income, but also poverty of trust as well. And then the third sort of leg of the stool, if you like, is the system side, which I think you're describing some of. So the digital skills and confidence and capability of staff, and also the understanding and motivation and interest in this. At a time when there's a lot of pressure on people on a daily basis. There's things like the infrastructure which you're talking about. There's access to Wi-Fi for from the health system side of things. And there's also one thing that we've sort of come across quite a lot, expectations. And I think I don't think the press have really helped, and I don't think that the NHS has often talked about, well, we're going to save a load of money by doing technology. And I don't think that's helped us, because then it makes it look like a cheaper, crapper option. And there's a real issue around sort of expectations and understanding of the value of digital. And sometimes it can provide often integrated as an enabler, not the end, can provide a really good quality, comprehensive sort of services. So there's that side of things that we must address as well at the same time, or we're going to end up with a two-tiered system. And we're going to end up leaving people who really need support and services behind.
No, I completely agree with that. And I think we need to remember the core reason of this space and the development in this space, and that's about the patient. We can't forget that. Digital's great, but digital doesn't mean it's always right for the patient. It doesn't mean that one size fits all. Sometimes digital's inappropriate, right? If a patient's got a problem, sometimes I want to see them more than sometimes I want to see them. We're not looking at the dynamic between and the interplay between the patient and the patient needs and the needs of actually seeing a medical professional face to face. There's a psychological impact that has as well. So it's about hybrid delivery of care. That's really, really important. I also think that in terms of the inequality, which is what you're describing, essentially, the inequality of care, and what do we do with patients that are subject to these inequalities? How do we change the space so that even if they don't have access to digital, that the digital can either come to them or that digital works at system level so the right professional comes to them? I think that's the other way of looking at it. So a couple of ways of doing that. Again, let's take the pandemic because we all know about that. We go to where the patients are. So there was a problem in my region where vaccine uptake was low, and patients weren't having it for many reasons. So what we did, we went to where the patients were. In one particular instance, we went to a religious building, a church where people congregated, and we spoke to the pastor, and we said, well, actually, look, within your congregation, we've identified a demographic that aren't getting the vaccine. We're here to talk to them. In fact, we've got the vaccination hub here that we're going to set up. What are your problems? What's going on? And by the way, whilst you're here, do you have any other concerns? Do you have any problems with any of your other medical needs? Let's signpost you correctly. Are you worried about diabetes? Are you worried about prostate cancer? Have you done X? Have you done Y? We showed them the other bits of the digital innovation that was there, but at a very simple level. Have you got phones? Let's get them out. Let's have a look. Let's get your app. Let's get your NHS app up and running for you. So it's things like that we did as well, which helps address digital inequality. And the other side of it is as well that the digital inequality and what it does in the social care space is also very, very important. And I don't think social care gets enough bandwidth, really, for what it needs. A great example would be how healthcare assistants have stepped up in the pandemic, especially in the social care space. So if I was to do a home visit, for example, prior to the pandemic, I would go in, I would do the observations, I would do the examination for the patient, and I'd come up with a management plan. Now, there is certainly still a space for that, and that still happens. But my healthcare assistants, they now in the community will have blood pressure machines, they have pulse oximeters. Some of the care homes even have a dashboard, and they monitor their patients, and they get that information over to me. I mean, that's a great example where the actual tech is not patient directly delivered to the patient, but the systems around the patient within the care home have used tech appropriately to increase the kind of level of care that we're delivering for that patient. So it's these systems of inequality. I think the final thing I'll say on inequality is changing the systems behind the problem. So what we're doing in my clinical commissioning group is I'm the primary care clinical lead executive for urgent and emergency care. I'm not alone. There are 19 of us in total. So we look at urgent and emergency care. We look at cardiology. We look at respiratory conditions. We look at SMI, so serious mental illness. We look at learning disability, diabetes. You name it, we've got a clinical lead executive looking at that particular condition and looking at how we address inequality in respect to digital and non-digital, because one size and one way of doing something does not suit the entire population, and it doesn't suit every clinical condition either. So we can't forget that it's about the patient and making sure that what we put in place, what systems we have, are flexible and adaptable enough for each patient. And by the way, if the patient still wants to come and see their GP face-to-face, we're doing it. But some of them go, actually, I'm at work, would you mind giving me a call because it means I don't have to take time off work? Or would you mind doing a quick video call for me? Yeah, of course I can. But if I still need to see you, I need to see you. If I don't need to see you and I've got an appropriate plan in place, that's fine. But you have that conversation with the patient and you make sure that you minimise inequality as far as possible.
I think it's really some of the things that are coming out from what you're saying, like listening to people, going to where people are, working in partnership with people who've got trusted touch points with the communities you're trying to reach, are some of the important sort of constructs of inclusion, I think. I just wanted to ask a final question, a couple of minutes before everybody can go and have some drinks and chat and listen to Simon Bolton. Is something about, what do we need from the national system to help us do this stuff well on the ground? Because I think, just to give a bit of reality check. You know, we've got the things like what good looks like coming out of what was NHSX. We've got that operational guidance. And I'm delighted to see that inclusion is starting to come into there, and delighted that the Director of Health Inequalities has now got a policy objective around digital inequalities. But, you know, what more could be done at a national level to help you do your job well?
Okay, so everyone's going to be delayed for an hour now, so this is what we're going to do at national level.
You've got 60 seconds.
Okay, it's going to be tough to summarise in 60 seconds. Okay, so I think the biggest problem we've got now is the backlog of care. So let's deal with that. What we need to do is try and deal with as many of our patients' needs in the primary care space and deal with it appropriately the first time in the right way. And in that way, we allow secondary care to get on with the backlog and deal with the huge weights that we've got. And I think national policy needs to shift so that it's recognised that if we look after patients with a chronic disease and their long-term illnesses and keep them out of hospital, out of the acute space for as long as possible, that limits who needs to go into use the secondary care space and allows our secondary care colleagues to get on with shifting the backlog. I think that needs to be really looked at and really, you know, drill down into what we can do in primary care. And there's so much that we can do in that space.
Brilliant.
I hope that was short enough.
Yeah, I've got two things to add. One is, for anybody that's working on digital transformation, before you start, think about who might be excluded and go and talk to them, listen to them and work with them to co-design inclusive digital transformation. And secondly, if there's anyone from the centre, my piece of advice would be to top slice 10% of every piece of digital transformation funding and make that go towards inclusion, and always ask the question in all your funding applications and so on, how are you going to make sure you don't compound pre-existing health inequalities through this digital transformation? That would be my last word on it.
Great.
Do you want to finish up, or are you done?
Well, it depends if we've got that hour or not, but there we go.
Honestly, I'd love to sit and talk to you for an hour. I think it's fantastic. So thank you so much for sharing that. And